really, I think we sort of talked about it, but the discussion topics, that we sort of opened with a discussion of the national ADAP crisis, overview of the Florida ADAP program, and trends which impacted ADAP growth here in the state, and cost containment activities. And I wanted to share a couple of the slides with some of the trend information, because I thought it was very, very informative, and you know, sort of how did the perfect storm align to contribute to the depth of the funding crisis that we're experiencing right now. One thing that Florida is known for is a very vigorous and dynamic public HIV testing program. And since 2006, 1.1 million people have been tested through the public sector here in Florida for HIV, and we've had a number of very high-profile testing initiatives. The African American Testing Initiative, ADAP, we've had Test Miami, other programs that are city-based. The result is that over 20,000 people have been identified HIV positive in Florida since 2006, and many of those have come to ADAP and our Ryan White programs for services. And for 2010, the trend continues that they will expect to at least match 2009 testing levels, if not exceed them. So we just have a very vigorous testing program, which is effective at finding newly infected people. Another thing, back in 2008, the NIH guidelines were updated, which recommended earlier treatment for people with higher CD4 counts. In fact, treatment was recommended for naive individuals with CD4 counts between 350 and 500. And while we can't be definitive from our data from the ADAP database, are people treatment naive when they come to us or not, we don't have that level of reporting capability. I found it interesting that over the past several years, the number of people at higher CD4 counts have increased a good bit. You can see back in 2007, there were 1,081 persons coming into the program with CD4 counts between 350 and 500. And as of September 23rd of this year, there were 1,894 who came to the program with CD4 values in that range. So that's another thing that's, I think, bringing people into treatment sooner rather than later. And this slide is simply a pictorial of our enrollment in the program from April 2009 until May 2010, and that was right before the wait list was actually implemented. We went from 2,035 persons in April 2009 to 2,509 persons in May 2010. So it's not a straight line uptick, but if you look at the trend, it definitely is an upward trend as far as monthly enrollments. And then another way of looking at that is as an annual enrollments. And I'll just comment, in 2006, 2007, after that year, there was a concerted effort to clean up the ADAP database. And a number of inactive cases were closed. Basically, each case was looked at to try and ensure that the cases reflected were actually active participants and not just files that were left open for whatever reason. So you'll notice that there was a slight dip in annual enrollments to 2007, 2008. But from that point on, it certainly has been a pretty substantial uptick. And since 2008, ADAP enrollment has gone up about 20%. And that is a pretty substantial number. And the economic recession, the challenges, the loss of insurance as people are laid off, I think all that contributed to the demand for ADAP services. And this is another slide that's very, very telling to me, and it really shows the stagnation and actually decrease in some of our ADAP funding versus the increase in enrollment and demand for services. If you look at the red line, back in 2006, we received $88 million and some change in our ADAP earmark. And then the Ryan White Care Act was reauthorized, and there was a change in the formula for allocating ADAP funds. You go to 2007, 2008, where we've been basically flatlined through the 2009-10 year at 83 million and just some very slight variation from year to year. If you look at the bottom, that shows our actual state general revenue support for ADAP. And back in 06-07, it was $10.5 million annually. And that continued level until the 09-10 year, when we actually took a $1 million hit as part of the challenge to balance our own state budget here in Florida. So you've got a decline in federal support, and then on top of that, you see the enrollments of ADAP participants. So that's a very, very good snapshot of level decreasing funding and increasing demand for services.
Joe, question. So on this particular graph, how was the Bureau able to sustain the gap between the enrollments and the actual revenue since fiscal year 2007 to 2008?
Well, in previous years, fortunately, we were not maxing out our allocation every year, and we were able to build some inventory in our central pharmacy, which was very helpful in dealing with some of the initial growth in the program. But when we started seeing that uptick in 20% increase in enrollment, it just sort of hit a plane that was beyond anything our inventory could sustain. And another thing I wanted to look at is just what are we doing with our ADAP revenues? And this slide is intended to show that, I think, fairly clearly. For the current year, our ADAP earmark is a little over $85 million, and we have $9.5 million in general revenue support, bringing total recurring revenues to about $95 million. $74 million of that $85 million goes directly to our central pharmacy for the procurement of medications. We have $9.5 million goes directly to our central pharmacy for the procurement of medications. There are no administrative dollars taken from the general revenue funds. 100% of that goes for pills. Part of the $85 million is the ADAP pharmaceutical contracts in Miami. That's $3.2 million of those categorical dollars go to support that, and that's essentially for direct services for ADAP medications. We do allocate $2.6 million in ADAP earmark funds for our AIDS insurance continuation program, because we realize the cost effectiveness of being able to buy insurance premium versus paying 100% of the cost of care and treatment services. And then we come to the administrative allowance, and it's $5 million, and that is inclusive of really everything. It goes from running the program at the headquarters level, county health departments, central pharmacy operations at 13 county health departments that have on-site pharmacies. Many of their expenses are run through those $5 million. And basically, we have no dispensing fees, so there's not another revenue source from the program to allow for administrative support. So that really is a comprehensive figure that goes from the program, running of the program, to actually delivery of the pills. And when we add all that up, it comes to the $94,688,435. So it's a fairly tight program. There's not a huge administrative allowance. Although we are looking at every dollar and continue to do that, that is basically a pictorial of where the dollars go.
Joe, can you explain again the ADAP pharmaceutical contract in Miami?
Yes, there are two contracts for ADAP services in Miami, and Miami is such a large area and has so many clients that the county health department is the predominant site for ADAP services, but you had a couple of contracts that were, I think, doing two things. It allowed for some relief of capacity concerns at the county health department, and it also allowed for specific populations to be targeted and I think well served in their community. So it did two things. There were capacity concerns at the pharmacy in Miami, and also this assisted with some of the targeting activities of trying to serve communities within the Miami area.
Has the ADAP program thought of outsourcing to other areas? Because if the health department is limited to hours, could you outsource to maybe other pharmacies that are open in the evenings or weekends? Has the Bureau considered that in other areas?
I think that's been sort of individual one-on-one kind of consideration. Of course, given the financial stress of the program now, I don't think now is a good time to do that, but if you feel like there's a need in your community to have a proposal to meet that need, I think that would certainly be a good discussion, and we would do everything we can to support what you think needs to be done to better serve your clients.
Thanks.
All right, and this is another way of looking at our funding and also the shortfall in the program. Looking at a pie chart. That's the $75.6 million that was on the previous chart for our appeal budget. Then you've got our $9.5 million in state funding, which is a big chunk of the pie. And then earlier in the year, when we were confirming our, when we got our grant award and actually went back and confirmed our budget, we were able to sweep $1.7 million in funds to ADAP. So that little slice is representative of that $1.7 million sweeps we did earlier this year. Then you come in, we added the $2.2 million in supplemental funds that we got. And the ADAP emergency shortfall funds of $6.9 million. And then our gap is in the $16 to $19 million range, and that is probably 2 months or a little less than 2 months of funding for our program at current expenditure rates. So this is the gap that we have been, looking under every stone to fill between now and March 31st. We do feel like we'll have some additional capacity after April 1, so our eye is getting us to April 1 with minimum disruption to the clients. And I'll talk about some of the things we're doing now to identify additional resources to bring to the program. One thing that we're doing, again, from Dr. Viamonte Ross's level down to the department is we're dialoguing about borrowing some general revenue from the department. There are trust funds and other accounts within the Department of Health that we're very interested if we could borrow some funds for a month or more of medications. We will certainly make whatever arrangements we need to pay that back after April 1. But that's one thing that is looking fairly positive at this point and will allow us to get closer to that April 1 date. Another thing that we've done just in the past couple of weeks is we've actually written a letter to HRSA. There is a policy allowance which allows you to potentially access grant funds up to 90 days prior to the beginning of the grant year. So we've asked HRSA to give us that flexibility for the 2011 Part B grant, and if granted, we potentially could access the grant dollars as early as January 1. Of course, we want to do that as judiciously as possible, because we realize any dollar we pull forward, we're going to have to make sure that we have adequate funding for the remainder of the 2011 year. But again, I think there's a feeling if we can get to April 1, we'll have some negotiating room that we really are just pressed for right now. The third thing that we're doing, we're speaking with Central Pharmacy and other staff in the fiscal world to see if we order drugs in March and we wanted to delay payment until April, what ramifications would there be? We know there's certain comptroller requirements about prompt payment. There may be some fines or penalties for payment outside of a certain window. But we're looking to see if that's something that we may be able to live with, to again assure that we get to April 1 with minimum disruption and client access to medications. So a lot of wheels are still churning, things are up in the air, but we are looking at every potential funding source to get us to April 1. I wish I could say conclusively that all of these are resounding affirmative, that we will have all these flexibilities that we're requesting, but I simply don't know that at this time. But we are continuing to work very hard on that.